Okay, to all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. This video will be available for review after this journal club. The information contained in the video content represents the views and opinions of the presenters and does not necessarily represent the views or opinions of Releve Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by Releve Sports Medicine or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have read or seen on the site. Releve Sports Medicine hereby disclaims any and all liability to any part or for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from any use of the video content, which is provided as is and without warranties. We are looking for an athletic trainer to join our team. This is a full-time clinic-based position working in a sports medicine clinic. Please feel free to pass our information along if you know of a qualified candidate. More information regarding applying can be found on our website. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. And I will be moderating those questions. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, consider swiping the screen to the left or to the right and the slides should become visible. So Dr. Jason Brucker is a triple boarded physician based in the New York Metropolitan area with interest in the spectrum of musculoskeletal disorders and preventive medicine. He began his training in Brooklyn, New York at SUNY Downstate Medical Center. After graduating from medical school in an internal medicine residency, he completed a rheumatology fellowship at Montefiore Medical Center in the Bronx, New York, followed by completion of a primary care sports medicine fellowship at Christiana Care Health Center in Wilmington, Delaware. He has served in multiple capacities as a sports medicine specialist, including past roles as team physician for Baruch College and New York Sharks of the Women's Football Alliance, as well as a member of the NYU Langone Medical Center Concussion Center. His current roles are primarily as a telemedicine physician for various platforms, as well as periodic sports medicine coverage, including most recently pre-participation evaluation for the National Football League and National Basketball League officiating staff. And so he will be speaking today on the rheumatology pearls for the athletic trainer.
Thank you so much for the introduction. I'm very, very excited to be able to speak to you all today. I've worked closely with athletic trainers, throughout the past in my career, and I feel like sports medicine physicians and ATCs are kindred spirits in the fact that we're in so many aspects of medicine, and often wear many different hats depending on the role, whether you're working in a more of a traditional sideline capacity, or if you're working in the office. So, and as such, you see pretty much everything, and sometimes things that are on the fringes of what you may think is of your expertise. And one of the things that I was able to learn on, was just how much there is an intersection between sports medicine and rheumatology, and certainly I came by way of becoming a sports medicine physician through my rheumatology fellowship. I didn't even know it was a pathway through the internal medicine track, which is the core of my training. And but I am always humbled by the cases that my colleagues, including Michelle, have presented to me and continues to stump me. It keeps you honest, but it also keeps everything fresh and fascinating. So, we're going to try and cover a bunch of topics today. Hopefully, some of this sticks. A lot of times, rheumatological diagnoses are diagnoses of exclusion, and sometimes they include a lot of orphan diseases, meaning things that don't necessarily subscribe to one specialty or are multidisciplinary. But we're definitely going to focus on mostly the musculoskeletal aspects and those conditions that have musculoskeletal involvement. Hopefully this will be higher yield, but certainly let me know at the end if there's anything else that I can go into more detail about. All right. Now, just the technical aspect, I got to learn how to share my screen here. Let's see.
Okay, so there should be a button that popped up onto the screen that asks if you want to share your screen.
Let's see.
And if that button seems to have gotten hidden, I can flip it back and then put it back out to you.
Yeah, that might be advisable. Yeah, I appreciate that.
Oh, hello. Wonderful. And your video started working.
There we go.
Yes.
That's good. Okay. Now, what do I need to do? This is where I show my age.
Did you have a little button pop up and it says show my screen, or no?
That didn't pop up yet. So let's see.
Okay, let me try. I can try it again. We have okay. Hopefully you got it. It popped up.
Let's see. All right, there's me again, and okay. Unfortunately, I'm not seeing a button here to share my screen.
Okay.
Apologize.
It looks like you've maybe two.
Oh, here we go. Yes, it just popped up.
Okay, wonderful. Oh, wonderful. We can see your screen now.
Okay, excellent. I appreciate that. Let me just get into slideshow mode and get down to brass tacks. All right, awesome. All right, sorry for that, but I'm sure nothing phases anyone in the pandemic era of working remotely. So I have no disclosures, and I'll just start by showing some popular, or I shouldn't say popular, but well-known sports athletes here. And as you may surmise, all four of these have rheumatologic conditions. Some recognize Venus Williams on the left there. She was diagnosed with Sjogren's well into her career, and she did have some musculoskeletal complaints that was something that she had initially just subscribed to. The wear and tear of being a professional athlete. Phil Mickelson, he was shilling Embro for a while before he was shilling Live Golf, and has psoriatic arthritis. Caroline Wozniak on the bottom there, tennis, she actually had to retire because of her rheumatoid arthritis diagnosis. Shannon Box up there in the top right has lupus, and that actually did contribute to her performance on the field at times, she had said, but thankfully she was able to continue practicing and had a full career. So, rheumatology, the point of this is not just to signify that rheumatologic conditions intersect with sports, but it can happen to anybody, whether you are a weekend warrior, you are a professional athlete. And just, a quick breakdown, it's more common than we know, and it's probably underdiagnosed. Lupus is, 20 to 150 cases for every 100,000 Americans. Rheumatoid arthritis is actually the most common autoimmune condition that's even higher than type 1 diabetes. Juvenile idiopathic arthritis, which used to be known as JIA, is commonly diagnosed and has many manifestations. Psoriatic arthritis, upwards of 1 to 4 million patients in the United States will develop psoriatic arthritis in somewhere on a continuum. So it's very common. Now, without really, putting numbers, just think about all the athletes at every level. 8 million scholastic athletes, almost 500,000 collegiate athletes, 12,000 professional athletes, with 25%, 1 in 4 American adults continue to play sports throughout their life. So, without trying to calculate it, you could do the math. There's going to be plenty of intersection just for daily life. So how do you define rheumatology? It's actually something that even rheumatologists have a hard time defining. Certainly it is the study of autoimmune conditions. It is inflammatory diseases, especially those that affect muscle joints and bones, specifically what we call diarthrodial joints. So those that have type 2 cartilage, and that is basically any joint that you can voluntarily move, essentially. That's a little bit of an oversimplification, but essentially that. It's connective tissue diseases, but there is certainly looser definitions depending on which aspect of rheumatology you present. But a lot of times it's more of okay, I don't know what's going on, let's send it to the rheumatologist. And of course, always the concern, lupus is a lupus. That's always the biggest concern. But as we'll talk about, probably the most common etiology is inflammatory disease with rheumatoid arthritis, psoriatic arthritis. But yeah, I can't tell you how many consultations I've had where the question was just lupus. How was it? So, when you try to think like a rheumatologist, it's a little bit different than thinking like an orthopedist. Orthopedist is usually you have a very pared down diagnosis, a local anatomical approach, or perhaps a symptom complex. And you're focusing a lot of times more on acute rather than chronic injury, but certainly looking more towards, biomechanical etiologies. Whereas with rheumatologists, it's more of a systems approach, and it tends to be, thinking for systemic causes in conjunction with the musculoskeletal involvement rather than, starting, there's hand pain, just focusing on that. It's a lot of hone out investigation. But certainly there is plenty of overlap, as we've alluded to. These can mimic acute sports injuries, but have a very different etiology. So a lot of times you'll see the same conditions in these different didactic textbooks, but the pathogenesis is completely different. Biomechanical derangements are something that are commonly seen and underappreciated by rheumatologists, and something that the sports medicine world has been able to identify and focus a lot of care on. That can be the trigger point, posterior chain weakness. It can be very challenging to resolve acute issues when the systemic problems are not adequately addressed. And again, that is something where, the intersection of sports medicine can actually be helpful for rheumatologists. And I can just tell you from personal experience, it wasn't until I started having rotations with physiatrists that I really started to appreciate the impact of trigger points and how that could shape my future practice and eventually lead me down the path of sports medicine. So this we're not going to go through all this, so we're going to take a deep breath, but just to give you kind of a flavor of how diverse and heterogeneous this study rheumatology is. But we're going to try and cover, the higher yield and the more common topics. So we'll talk about lupus, we'll talk about inflammatory arthritis, we'll talk about the ones that are seronegative, meaning they don't have markers, and those can be a little bit more challenging to diagnose. We're going to cover a little bit of osteoarthritis too, degenerative conditions, because that can often sometimes be confused or present similarly to inflammatory arthritis. And then, I'll be talking about the evaluation exam throughout, but then we'll touch down on it just, special considerations in how to approach the rheumatologic patient. So any Seinfeld fans in the audience, I mean, again, this is always the question is of lupus. And lupus in itself is a very heterogeneous condition, and it can present with very many subtypes. But there is a lot of musculoskeletal involvement that can occur. Let me advance the next slide here. So some of the clinical features, just starting off with fatigue, myalgias, weight changes, things that are very subjective. Specific organ involvement, it can range. And joint pain is very common, but it can also involve pretty much any organ system. Sometimes certain phenomenon like Raynaud's phenomenon, where you're getting, which is a vascular etiology, you're getting the changes in coloration of fingers, followed by hyperemia upon rewarming, that can present with musculoskeletal complaints. So sometimes it's hard to separate, is this immune-related phenomena that's causing the pain? Is this more just, a compensatory or sequelae of the underlying condition? So pretty much any organ system can be affected by lupus, but usually you need at least 4 criteria in order to diagnose lupus, and that usually requires autoantibody testing, and then these other organ systems. So, you don't have to remember this. The little mnemonic was SOAP Brain MD, in case anyone was reading vertically there. But, I'll just show you a couple salient features, because it's hard to just, remember criteria. It's a lot easier to just think of pictures and kind of have that aspect. So, the first thing is skin involvement. It's very common in lupus. You can see the classic butterfly rash. It's sparing the nasolabial folds. That can sometimes be confused by rosacea, which is also photosensitive and a very common etiology. That does not spare the nasolabial folds, so that's something important. And that's what, again, whenever you're seeing a patient, the first thing is going to be inspection. It's going to be skin, and a lot of times you're going to see skin involvement in all these conditions, and that's going to be the first thing you notice. This is showing discoid lesion, which has predilection for the scalp, hairline, and ears. Theo, famous singer, he actually has old discoid scars on his face. There's a lot of speculation these were, tribal tattoos or scars, but he had discoid lupus. Oral abscess ulcers, which is very non-specific. You get them with COVID, you get them with hand, foot, and mouth disease and pediatric illnesses, but it's a feature that's common in lupus. And then the Raynaud's that I mentioned, which can sometimes result in musculoskeletal manifestations. So I mentioned this, even though this is kind of out of what we're going to talk about in terms of musculoskeletal involvement. Keeping these in the backdrop of your mind can help you kind of shape what to expect with the joint pain. So it's always good to have that in the back of your mind. But in terms of lupus, usually the joint pain is non-erosive, meaning it's not affecting the bones, not destroying the bones. It's usually more somatic complaints, subjective complaints, not too different than if you had an illness. You had a virus or a flu. You think about the pains, the aches and pains that you get with that, and that's, to be honest with you, that's a lot of how patients with lupus feel with their joints every day. They can have hypermobility, and it's certainly possible to have an overlap with hypermobility. So when you do have a patient that may have a benign joint hypermobility or Ehlers-Danlos-like picture, it's important just to keep in the back of mind. Could this be something more of the autoimmune subtype? More advanced cases, it's not as common, but you can get what's called a Jacquard's arthropathy. You get ulnar deviation of the thickness of the fingers. I'll show you a picture of that later. And you can get an AVN, and a lot of times it's iatrogenic due to prednisone use. As I mentioned, there is that intersection of sports medicine where you'll see sports medicine conditions, but completely different etiology. So Freiberg's disease, which is an uncommon disease that you can sometimes see in runners and other impact sports where impact heavy with the feet, you can get a Freiberg's disease, and that usually affects the second or third metatarsal base, and that's what this picture is showing. and that's because of vascular compromise. Here's a picture of Jacquard's arthritis, and again, that's not something that you're commonly going to see, but if you do see, swan necking or this ulnar deviation, then that can be something in the back of your mind. But again, that's usually non-erosive. Sorry, I went back too far here. When you're doing the joint exam, I like to sweep the fingers. So I like to start at the base on the side and kind of sweep towards the front. And and you do a range of motion exam. You want to look for laxity. You can have your patient put your hand on the bed, just press on the hand, press down, and see if there's any additional deviation. Compare it to both hands. You always want to do bilateral exams. Here you can see a swan neck deformity there, also known as a goose neck. When they're in the thumb, it's referred to as a Z sign, although I guess that would only be if it was the right thumb, I believe. Otherwise, it'd be a mirror image. You can get pretty much any joint affected, but in particular the small joints, the MCPs, the PIPs are most commonly affected. As I mentioned, lupus can overlap pretty many diseases. Lupus itself is a very horrible disease. It doesn't often follow the rules. There can be rheumatoid arthritis. Lupus overlaps so-called lupus, where you do get an inflammatory, erosive disease, but then you also get some more of the systemic features, and it can be very challenging. But just important to know that there's so many different aspects and a lot of psychiatric involvement, and certainly that in itself can have indirect effects on somatic symptoms. Moving on to Sjogren's, as I mentioned, Venus Williams, it was probably the most famous patient athlete to be diagnosed with this. It's also known as Sicca syndrome, and typically it follows a benign course. You get the dry eyes, you get the dry mouth. It can sometimes result in parotid swelling, as shown in this picture. There are objective testing to do it. This is showing Schirmer's test, which basically you're trying to see objectively how much tears there are. If it's less than 5 millimeters over a period of time, then that's considered a positive test. There's other more invasive tests, that's out of the scope of what we're talking about today. But, there can be a lot of joint involvement too. Sometimes it's more nonspecific, just arthralgias, myalgias, but it can actually lead to a very similar pattern to rheumatoid arthritis. It can overlap with rheumatoid arthritis. It's not uncommon for patients to have a rheumatoid factor positivity and or frank overlap. There's an increased risk for lymphoma and cancers. Cancers obviously lead to a lot of bone pain and joint and muscle pain too. So it's unfortunately, there's many different manifestations for the joint pain. It can sometimes be difficult to know, is this something belonging to be more serious, or is this more par and par for the course? Rheumatoid arthritis is probably the most commonly seen bread and butter illness that's seen in the rheumatologic world. And thanks to the advent of so many medications, we're never going to see a lot of the pictures that I'm going to show you. So this is a more advanced case. This actually looks like there is probably some degenerative arthritis in this patient. Probably has some Heberden's nodes and Bouchard's nodes, which is the swelling of the MCPs and DIPs, the DIPs and MCPs. And I'll show another picture of that a little more classically. But again, you're going to sweep the fingers. You're going to have them put their hands down in front of you. You can assess range of motion. Checking excursion. Can you touch your palm? The tips of your fingers to your palm. You want to just see what the range of motion, what their grip strength is. All these different aspects, and of course, tenderness on the joints. It can lead to a destructive arthropathy. Women are more commonly affected than men, and can have extra articular manifestations as well, but certainly the joint pain, especially the small joints, is most notable. These are some of the advanced manifestations. You'll hopefully never see this. I have seen it in the Bronx. A lot of patients were in underserved areas, or they were coming from the Caribbean or other countries, often illegally living in the Bronx. And so here in the top right, you see a telescoping arthritis mutilans. Basically, this patient's joints are completely destroyed. Ironically, once they get to that point, they no longer have any inflammation because there's nothing left to be inflamed and you can see just other joint destruction in the X-ray corresponding next to it. They can get, you can pretty much get any joint, as I mentioned, any arterial joint, any type 2 cartilage joint. So they can get hearing loss. They can get a lot of bad TMJ, and you can actually get instability, atlantal axial instability, and that's what this picture is showing. So flexion extension X-rays become very important in the orthopedic practice. And it's unfortunately a very challenging disease because the quality of the bone is hard. And I've talked to a lot of orthopedic surgeons who have tried to, do joint replacements. And they say it's like trying to put a screw into sand. It's very hard to get a lot of these things to take. And so it can be very challenging from an orthopedic standpoint as well. Here, I believe this picture, you can see how this patient is actually trying to extend all the fingers, but you can see that little swelling there. That's not a ganglion cyst. That's actually tendon rupture, extensor tendon rupture, just because of stenosing tenosynovitis, which is chronic inflammation. So you will see a lot of trigger fingers in your practice. When it happens with rheumatoid arthritis, it's usually a lot more advanced, and it can actually lead to complete failure of these tendons, lead to profound inflammation. So hopefully with all these new medications, biologics, we're not going to see a lot less and less and less of this. But there are some patients, unfortunately, either just because of how advanced your disease is, or just the fact that they are not seeing their doctor. But as I mentioned, accelerated arthritis, when it's untreated, you can get rheumatoid nodules too, and that can be painful, but most commonly is painless. And then there are sports medicine-like injuries, but again, from a different etiology. So gamekeeper's thumb, or as we more commonly know as skier's thumb, when it's an acute injury, you can see that with rheumatoid arthritis. I've never seen a Center's lesion, but that is something that is possible. I had a colleague that had that in the rheumatologic practice. If you ever have a patient that presents with, any abnormal tendon involvement, any abnormal joint involvement, something that's like the mechanism doesn't seem to match. Think rheumatoid arthritis. If you take anything from that point, it's just, tendinopathies, weird tendinopathies, just keep that in the back of your mind, especially if it's symmetric. As I mentioned, stenosing tenosynovitis. You can get proliferative synovitis in the wrist, so this will result not just in swelling, but decreased range of motion and a lot of morning stiffness. So the salient features: wake up in the morning, not being able to move. I remember I went to a conference once, and they had these special gloves that were filled with sand, and it feels a lot of times to speak to a patient, it's heavy, it's hard to grip objects, it's hard to move. As I mentioned, consider flag if it involves an uncommon tendon extensor, tendinopathy of the fingers or wrist, flexor pollicis longus tendinopathy, for instance, or not in contact with the support, something that's not commonly injured. PIP, MCP, and joint involvement are classic, but any large joint can also be involved. Not as common in spine, but other than the C-spine, but it is possible. You can get what's called a boutonniere's deformity, and let me see if I can load this video here. It worked earlier. Hopefully you guys are still. Oh, you guys have to see a Fresh Direct commercial. All right, I'm sorry. All right, here we go. So I just thought, that's not a common test that we do, but it is a good test to, if it's not, clear that the patient has a boutonniere deformity, that can elicit that. So just bring this back into full screen here. The foot is actually something that's under-recognized. I actually think when evaluating rheumatoid arthritis, we always focus on the hands, but and many times the stiffness and the joint swelling occurs in the feet before it does occur in the hands. You can see common deformities that you would see in dancers, for instance, hallux valgus, Morton's neuromas. The Liz Frank injury is showing you the classic sports etiology, but patients will get rheumatoid arthritis. Patients will get this without the precipitating event. Retrocranial bursitis is something that is sometimes be a heralding sign, especially if it's bilateral. So one thing to keep in mind. And just showing you the common distributions here. OA is in the hands will usually involve the DIPs and the PIPs. Psoriatic arthritis can also have that distribution too. When you see X-rays, you'll see erosions. With OA, you will see more of a seagull-like sign, kind of a weavy line. You'll see hook deformities, but with erosions, for RA, you'll actually see decreased bone with a periarticular formation of new bone, showing that it's the ongoing inflammatory process. So you get this periarticular osteopenia. With other conditions, you can actually get quite the opposite. Degenerative joint disease, as I mentioned, can sometimes mimic. In really severe cases, you can get formation of synovial cysts. This is, interestingly enough, not just more common in women. They think maybe because of joint laxity, maybe especially if there was due to oxytocin levels earlier on. But there is also the thought that osteoarthritis, those who have more of a erosive osteoarthritis or advanced osteoarthritis in the hands, may confirm actually a protected benefit of arthritis in other joints. It's kind of interesting, but can also mimic rheumatoid arthritis. I'm not going to go into too much detail with JIA because it's actually a group of multiple diseases. It used to be called just juvenile rheumatoid arthritis, but that is only one subtype of juvenile idiopathic arthritis. It tends to affect mostly kids aged 7 to 12. It can sometimes be hard to differentiate, but these precursor lesions can eventually lead to evolution to adult forms of these diseases. So there's about 5 or 6 subtypes. The way with kids, if you take care of kids, one of the things to look for is the patient afraid, is the athlete afraid to engage in physical activity? Are they favoring something? Not necessarily complaining of pain, but are they favoring something? Are they limiting use? And that could present as a limp. That could present as just trying avoidance of certain maneuvers or certain sports. So that's the kinesphobia, which is a new term for me. I never heard it in my entire career, but the avoidance of certain activities. But it's actually something that is probably under-recognized. There's not a lot of pediatric rheumatologists in the country, and it's something that I think sometimes just flies under the radar. And I won't go into this, but there is certainly the whole gamut of reasons and etiologies for JA, and it's just a wide differential for what could be causing these pains. As I mentioned, symptoms are often non-specific. Look for the abnormal gait, limping, especially in younger children. Is there persistent flu-like symptoms? I think, unfortunately, I'll just put in a word here. I didn't mention it in the presentation, but with COVID now, everything is COVID into proven otherwise. Before it was lupus into proven otherwise. But it's a lot of these non-specific somatic symptoms. Cardinal clinical features would be persistent swelling. So obviously, it can affect any joint, but in particular, the larger joints or the median joints are affected. In younger kids, it may not even present with pain, but just a limp. It may present with swelling that gets better throughout the day, but unfortunately, there's no specific pattern a lot of times. As I mentioned, there's 5 subtypes, and you don't have to commit any of this to memory. It's perfect classification system. Not all of these have positive markers, but when you do break it down, it's kind of sometimes interesting if you have a patient, an adult patient who has rheumatoid arthritis, an adult patient has lupus, and you kind of go back into their medical records. Sometimes you can piece together, oh, maybe they did actually have one of these subtypes of JIA, but 1 in 1,000 children may be affected by JIA, so it's definitely under-recognized. I'll focus on polyarthritis because that is one of the ones that is seen probably in populations that you guys take care of, the teenage population. It can be symmetric or asymmetric. It affects small joints, the hands, and it can also affect more uncommon joints, as I mentioned, the TMJ, cervical spine. It loosely correlates with rheumatoid arthritis or seronegative inflammatory arthropathies in adults. So when you're looking at this population, if you look at the right-sided chart, usually has a relatively rapid onset, multiple joints, may follow actually a viral illness or some sort of insult, and it can often just happen insidiously too. But usually in this population, more pain than stiffness or inflammation. So moving on, psoriatic arthritis. Phil Mickelson obviously has been shilling his Enbrel for a while, but there's a lot of other medications out there. 1 in 4 patients with psoriasis will go on to develop psoriasis. The funny thing that is kind of funky is you can actually present with psoriasis years before, and it can be under control and then develop psoriatic arthritis. And conversely, you can develop psoriatic arthritis first and then later develop psoriasis. So it doesn't really follow any particular pattern. It definitely tends to occur in various groups, but it's not one specific pattern. There's actually about 5 different patterns. The most common is asymmetric involvement involving the smaller joints. There is also some that involves more of a rheumatoid arthritis pattern. It can also involve the axial skeleton, meaning the sacroiliac joints. It can sometimes masquerade as other illnesses, and sometimes can even appear to be like a migratory arthritis, even though it classically does not present that way. So unfortunately, it'd be very hard to diagnose negative seromarkers. So you have to have an index of clinical suspicion in order to diagnose it. But the classic is more of a distal arthritis, DFP changes. Look at the nails. If the patient's complaining of pain, you may be seeing them because of hand pain. Look at the nails. They're pitting in the nails, almost as someone took an owl and it made a lot of dots in their nails. Do they have any around the nail bed, any vascular changes, any capillary dropout? And certainly if they have x-rays, the classic pencil and cup is not always seen, but with signs of more advanced disease. Periarticular deposition rather than osteopenia is common as well. And I don't want to get down. It can get very hard when you start talking about criteria and diagnosis. I didn't want to go over that because obviously there's a lot of information. It's hard to absorb everything. But if you ever want to look up CASPAR, you can go to MD Calc and other websites that have calculators. That can sometimes be unsure. You can plug in go through the questions, plug in the answers, and that can sometimes be a useful tool if you have some index of suspicion. Like this is showing a sausage digit, dactylitis, and that's one of the classification criteria that's part of the CASPAR criteria. One of the interesting things, whenever you talk about seronegative spinal arthropathy, so seronegative arthritis is essentially not rheumatoid arthritis. It's a fancy way of saying not rheumatoid arthritis, meaning that there isn't positive disease markers. It doesn't always have elevated inflammatory markers. It can present with just a couple of joints. It may wax and wane, and it sometimes escapes diagnoses. It can be due to many different things. Following illness. It can be following. It can be due to psoriasis, as I mentioned. It can be due to other autoimmune phenomena. There's very different subtypes. But one of the classic things is heel pain, back pain and heel pain. And in fact, if you have the triad of elevated inflammatory markers, heel pain, and back pain, then there is a increased likelihood that this could be a seronegative arthritis. But tenosynovitis, dactylitis, sausages, enthesitis, typically the Achilles, but it can involve It could be a patellar tendonitis, it could be an elbow. And again, think about the context. This is not somebody who's not an overuse injury. Why is this patient getting these tendinopathies? Have that index of suspicion. Gout, interestingly enough, is more common as well, and sometimes some of the pain is related to gout. Usually gout, you're not going to see it in your collegiate or scholastic population unless it is a genetic condition. So 99% of the time, gout is an under excretion rather than an overproducer of uric acid. With psoriasis, because there's more cellular turnover, you accumulate more uric acid. But that's still going to be more common in the older population. And that's someone's artistic depiction of podagra there. And if you've had anyone who has had gout, even putting a bed sheet on that toe is extremely painful. Reactive arthritis also is under that umbrella of the seronegative spondyloarthropathies. Typically falls one of those GI illnesses, especially those that cause bloody diarrhea: Salmonella, Shigella, Campylobacter, Yersinia. Chlamydia is also something that can be associated with reactive arthritis. So in your sexually active populations, especially if there's unprotected sex and multiple partners, that's always something. And so the classic triad: can't see, can't pee. I knew it as can't climb a tree, but this one says can't bend a knee. I kind of like that better. So that classic triad, if you have that, dig a little bit more into history. But one of the other things important to note, we worry about, Lyme arthritis. We worry about, post-streptococcal arthritis. The pattern, is it a migratory arthritis? Is it an additive arthritis? Or is it just staying in that joint? And certainly sometimes with chlamydia, patients can get gonorrhea. That tends to present a little bit differently. That's going to be behave more like a septic joint, but often culture negative. But sometimes that can come part and parcel with that at the same time. Ankylosing spondylitis. I wish I should have included the classic picture of this gentleman who's 20 years old and he's bent over. He's extremely kyphotic and bent over using a cane. It's known pathologically causing the bamboo spine because of inflammation that leads basically to fusion of the vertebral bodies. It's symmetric, so both the SI joints will be involved, and that's important to compare against psoriatic arthritis, which should be asymptomatic. Extreme stiffness. When you're doing an assessment, in addition to here, you see squaring of the vertebrae on the left here, showing ankylosing spondylitis, more advanced ankylosing spondylitis with bridging. That's to be differentiated than diffuse idiopathic. I'm drawing like spinal hypertrophy, where you get more of these bridging osteophytes, but you don't get squaring. That's a benign condition. Sometimes gets confused. You can get both a peripheral ankylosing spondylitis, and you can get more of an axial involvement. With the axial involvement, you're going to have more stiffness, as you can see in the little stick man picture there. Normally, when we bend over, we're going to have reversal of the lumbar lordosis. We're going to have curvature. When you have ankylosing spondylitis, you can have stiffening of the spine. So, it's very common, in all athletes to get, back tightness, spasms. And yeah, sometimes we can get like this tightening of our erector spine, and it may seem that, okay, we're getting some straightening of the spine. But when you do the Schober's test, you should still have some curvature, even unless it's extreme spasm. In those cases, sometimes addressing the trigger points and then repeating the test can be helpful. But with the Schober's test, basically the modified Schober's test, basically, and I don't even always use a ruler measuring tape. I'll just use a piece of string or even a glove, and you're just having them. You identify those dimples of Venus on the back. You even mark with a marking pen and have them bend over, and you want to just see that they have that expansion. To see if really there is no expansion, then maybe that makes you more inclined to get an X-ray to get a little bit more history. Doing the Patrick's test or Faber's test, a lot of times this can also elicit the SI joint symptoms if it's bilateral in particular. And again, these are non-specific tests, but if you have that index of suspicion, then it can help you lead you down that pathway. One thing I didn't include here too, a very useful test is Thomas's test, and using that a lot of times can help you elicit not just back tightness, but hamstring tightness. You'll notice with all of these inflammatory arthropathies, there's just so many other concomitant pathology, musculoskeletal pathology, but these can be very helpful as well. Inflammatory myositis is not as common, and you may not actually see this, but it is mentioned a lot because there's a lot of confusion about what inflammatory myositis is. It doesn't present really with pain, and I think that's in contrast to polymyalgia rheumatica, which is a condition where you get shoulder pain and hip girdle pain. It happens often in older patients, typically older than 60, at least older than 50, and is associated with elevated inflammatory markers. Inflammatory myositis is an autoimmune condition where you've got muscle breakdowns, an autoimmune mediated muscle breakdown. It affects the proximal muscle groups, both shoulder and hip girdles, but the CBKs are going to be very high. So you're dealing with a case of rhabdo, but you don't have the inciting event. Didn't run a marathon, didn't perform heavy lifting. Then that's when you should start thinking, especially if there's profound weakness out of proportion to what you would expect. There can be skin involvement as well. So here showing the heliotrope rash in the middle, Groton's nodules on the top screen. There's going to be, I mentioned earlier, with psoriatic arthritis, sometimes you can see some nail changes. You can see nail changes here too. And one of the patterns is actually, you see those little red dots at the nail bed. That's capillary dropout because of the ablation of those capillaries. And some subtypes you can get what's called mechanic's hands, really peeling and skin. So, it's hard to not to do examination of skin whenever you're doing a joint exam. And so these are just things just to keep in the back of your mind. But again, it doesn't typically present with pain. If it's present with pain, it's probably not inflammatory myositis. But if it's weakness, profound weakness, progressive weakness, bilateral weakness, then that's when you might start to think about that. Fibromyalgia, unfortunately, is a very challenging diagnosis, not just to make, but to treat. It's often secondary to other conditions. It's a lot of times a wastebasket diagnosis. And one of my cynical rheumatology attendings says it was like the Illuminati creating this so rheumatologists would have something to bill when they couldn't figure out what was going on. But all joking aside, fibromyalgia can present with a lot of pain. It can sometimes be hard to differentiate this from, say, complex regional pain syndrome, formerly known as reflex sympathetic dystrophy, or just all other allodynia or other myofascial pain syndromes. But the essential idea is that there's pain out of proportion to the insult. There's a lot of times overlap with psychiatric conditions or other chronic medical conditions. But it classically involves pain, tenderness over the 11 out of 18 trigger points. This is not a very specific test, and there's unfortunately a lot of user error in defining this. Like how hard do you press? Well, you have to press enough basically to blanch a fingernail, which equates to about 4 newtons of force. They even sell dynamometers, if you really want to be very specific. I never invested in one of those. I don't think anyone should. But unfortunately, it's not something that you can just treat on itself. You have to treat the underlying conditions. And yes, there are other treatments that are geared toward fibromyalgia, gabapentin, other neurotropic pain medications. But ultimately, with fibromyalgia, it's a lot of times challenging in addressing the underlying condition. So that's just my word on fibromyalgia. You'll hear a lot, you'll see a lot, but it's not something that has any specific joint or muscle pathology. And again, just to mention the overlap of a lot of other conditions. I went back. So, we kind of did a whirlwind tour of these common muscular joint pathologies and talking about the exam. Just to kind of go back towards the exam, when you're evaluating patients, I really think the approach actually should be the same. You start by, visual inspection, and that will include the skin as well, but visual inspection of the joints, how they're walking, how they're standing, what they're favoring. And you want to use the contralateral body parts as your guide, especially if they're only complaining one area. Obviously, if they're complaining everything hurts, and then it becomes more of a challenge. See how they walk, see how they stand. Range of motion. I like to just basically say, we're going to do a little bit of yoga and stand up and, sunrise salutation, get your arms out of the way, see what their extension is. And it's okay to start out just generally moving and then, get them a little bit loose, and then they can start to palpate the joints. I would say, generally speaking, too, when you're advising patients, you want to also first get a sense of what the typical day is. What do you do getting up in the morning, and what's your exercise routine? When it comes to the specific exam, ask them to reproduce. What is it? What can you do to make it hurt? Like what particular motions? Have them try and replicate it. And I think these are kind of the same approaches that you would do with this traditional orthopedic examination. And then you get to the exam, a range of motion, palpation, tenderness. You'll do a focus on the sides of the joints, looking for a fusion. It's pretty much the same approach, but just having in the back of your mind that could this be due to a systemic cause. But as I mentioned, rheumatology a lot of times doesn't put a lot of emphasis on the ultrabiomechanics. They're so concerned about what is the underlying etiology that sometimes you forget about. Sometimes these trigger points in ultrabiomechanics and asymmetries and muscular imbalances can actually accentuate these problems, and then it becomes somewhat of catch-22. Well, I've got this ongoing joint inflammation, so now I'm compensating with these other muscle groups, and then those get injured, and because those get injured, then I'm less inclined to move and work out, and that's just going to accentuate my problem. So I think that's one of the important things that those from in the rheumatology world have to address. But definitely, when you think of the traditional rheumatoid arthritis and joint distribution, looking at those small joints, you can start. I like to start, out to in. Other people like to start with smaller joints and then work their way out. But it does basically involve a comparative exam, and not just focusing on or perhaps the area that is bothering the most, but sometimes you'll encounter some subtle pathology in other areas, looking for swelling. As I mentioned, putting the hands on resting the hands on a surface sometimes can elicit some subtle swelling. I had a colleague. His name is John Harden. He's the vice president of the Arthritis Foundation. He worked in orthopedic practice a lot, and he would a lot of times see this what he would call fat pad sign, and that's what I try to show in this picture. It's not a great picture, that bottom right there, but just proximal to the wrist there. Sometimes there's a little bit of puffiness there, and sometimes it's subtle things like that, tenting of the skin, or just a little bit of swelling is something that maybe the patient's not complaining about, some subtle changes. Just if you have that index of suspicion, then you may just beg the question, maybe we need to dig a little bit deeper. But just being careful with the exam, I think that's the basic points that I can make with that. As I mentioned, with rheumatologic patients, if they have an established diagnosis, they're going to have trigger points. They're going to have core and postural weakness. They're going to have a lot of deficiencies. So it's important also to address those. Even if they're coming in, they're saying, yeah, it's actually, my rheumatoid arthritis is under control, and now I just have, degenerative arthritis. But look at their hamstring tightness. They're not engaging their glutes, their core. So a lot of times addressing that. And then keeping in mind that these affect every other parameter of our life: sleep, hygiene, mental health, nutrition are profoundly affected. These are aspects that we in the sports medicine realm that we're constantly harping on and educating our patients on. And that goes for rheumatoid arthritis patients too. It's easy to lose the forest for the trees. Sometimes you're focusing on joints and you forget these other aspects. Other special considerations with lupus, as I mentioned, they get a photosensitive rash, the malware rash. Sunlight is basically poison. So these can trigger flares. Even if there's conditions added, in control, they go into the sun, and next thing you know, they have a flare and it's affected your joint. So it's one of the things that you can counsel your patients on. And vitamin D supplementation too, because if they're going to be avoiding the sun, they need to supplement with vitamin D. With inflammatory arthritis, just be mindful of their joints. They may be a little bit more tender, apprehensive when you're examining them. So just, kid glove approach initially, especially if it's your first time meeting them. As I mentioned, stiffness. One of the things that my patients actually liked a lot were these paraffin baths. And it was very helpful. It was one of the things that would do in the occupation therapy a lot. And then even if the patient is coming in, is after rheumatoid arthritis and they're addressing more of an hand issue, you have to keep in back in mind other joints involved, instability, and this becomes very important with preoperative clearance. Should patients with a very a positive history of rheumatoid arthritis or complications, should they be in contact sports? I would be inclined to say no. There's no specific guidelines through the auspices of rheumatology in terms of pre-participation sports, but perhaps there should, and I think this is a discussion for another time. Inflammatory myopathy, as I mentioned, it's a hip and shoulder girdle weakness, so you want to focus on core strength and posterior chain. Special consideration I was alluding to with pre-participation, I think everything has to be tailored to the individual athlete, and certainly so many times before, if you go back 30 years, 40 years, or not even 20 years, because there wasn't as many treatments available, you're not talking about athletes with these conditions or getting them back to sport. But we've gotten to a point now where we have so many tools in our toolbox on how to address these conditions. Now it begs the question, what can they do? And if it's a contact sport or it's a sport that involves hyperextension, this is a consideration. Unfortunately, rheumatologists, they don't have extensive familiarity with physiology and how to approach this sometimes. So I think there needs to be emphasis on the interdisciplinary approach. So involving physiotherapists, strength conditioning experts, nutritionists, definitely a committee approach is helpful. And just a quick word. To my knowledge, no DMARD or let alone glucocorticoids fall under NCAA advanced substances list. I correct me if I'm wrong about the glucocorticoids. I don't believe that's the case, but certainly that is something that you want to just be mindful of. There's always new drugs that are coming to the market. Here showing the benefit of aquatherapy. I think generally patients can benefit from this in general, especially if they're apprehensive with joint movement. So aquatherapy is great. Occupational therapists a lot of times create custom orthoses and devices, and this can be helpful. I think especially in certain sports that are risk intensive, whether it be tennis, whether it be gymnastics, be helpful to get them into occupational therapy to work on seeing if there's a way to tailor a device for them with these, even if they're not actively having complaints. Kerosene baths, I mentioned, are really nice. And then modified tools just on a daily basis. Patients really do require a modification of their daily devices. Compression stockings, I think, are great, not just for the physical relief, but can help with proprioception. I think that's one of the other things too. When you become apprehensive, it's a user or loser phenomenon, and that's what leads to all these mechanical balances. And other therapies, devices can be helpful certainly for the older non-athletic population, but also for athletes too. Using assisted devices, taking the load off of some of these well joints. So this is just showing some of these occupational devices are common for rheumatoid arthritis. So that's pretty much it. It's a whirlwind. I packed probably a lot more information than I needed to. It's something that's easy to keep talking about as we go. through this. I'm more than happy to answer any questions though, but hopefully we gives you a flavor of kind of spectrum of rheumatoid arthritis, how to put on those different hats, how to approach it from more of a rheumatologic standpoint than, orthopedic or sports medicine approach, and how to toggle between. But hope you found it informative, and happy to take any questions. Thank you so much.
Awesome, thank you. And I am going to. Okay, so we have had a couple of questions, so I am going to go ahead and pose those to you. The first one comes from Professor Terrell, coming from Florida Southern College, and she asks, can you speak more to the relationship of nutrition with rheumatoid arthritis? Are there recommended foods to avoid or include in someone's diet?
That's a fantastic question. I think that's an ongoing area of investigation. Just in the listserv that Dr. Henney and myself are part of, there's a lot of discussion about like anti-inflammatory diet. We hear this a lot, and certainly with integrative medicine becoming more popular, we hear about this. So there isn't a specific diet that you need to adhere to. I would generally say, if you can include more fruits and vegetables into your diet, you're going to do better. Not just from the standpoint of the polyphenols and the anti-inflammatory components of this, but just in generally, patients who have these inflammatory conditions, they gain weight. The cortisol levels are affected. They have poor diets. So there is definitely a strong link between not just obesity, but hyperlipidemia and cardiovascular disease with all these connective tissue diseases. So I was part of a study when I was a fellow, and you would see a strong correlation between hyperlipidemia and metabolic syndrome, in particular with psoriatic arthritis, but also with rheumatoid arthritis. So if you can encourage a patient to lose weight, to eat heart healthy, it's probably not it's going to take load off their joints, right? I like to tell patients, every pound you lose, it's 4 pounds off your knees. But it's also going to probably have other benefits towards their actually ongoing pathology. And I do have patients that it boggles my mind. They have advanced arthritis, or I wouldn't say advanced, but active arthritis. They go on these vegan diets, and then next thing you know, they don't have any pain, and I can't always explain it, So there's probably, pro-inflammatory components in animal protein that, are fuel for the fire, so to speak. I would just say one thing that's important: vitamin D deficiency is something that's pathologic in these conditions. So supplementing vitamin D is very important. I know there's been more recent studies, one that was in B&J, saying how vitamin D supplementation is not necessarily beneficial for patients. But when it comes to rheumatoid arthritis and inflammatory arthritis, it's still very important. But no, that's a great question. But yeah, I always like to tell patients, anything that's purple, eat it. It's great. Blackberries, blueberries, purple yams, ube, it's all good.
Okay, the next question is about the choice of rheumatoid arthritis medications and consideration for side effects to certain medications that may cause you to pursue other medications, or maybe their response to medications. So they were just asking, have you seen side effects with rheumatoid arthritis drugs that have caused you to pursue a different plan of action with your patients?
Yeah, all the time. It's very hard to say what's the right approach. It used to be for rheumatoid arthritis, everyone got methotrexate, and then you had to worry about hair loss and ulcers in the mouth and liver abnormalities, and then you would step up as needed. Now there's a much different approach with a lot of these newer biologic medications, and they're not all injections either. Patients have gone that route, and certainly they have to worry about things like malignancy. There could be affecting your humoral immunity, which is important for surveilling our body for cancer. And so there's increased risk for lymphoma, but these medications have really been game changers, and now it's more of a step down therapy, starting with these more advanced treatments and then backing off as needed. And a lot of times they have a lot less side effects than the more traditional ZMARs. certainly all these are favorable, more favorable than prednisone. Unfortunately, that is a necessary evil, especially when you're dealing with a flare and you have to go ahead, but prednisone is going to lead to weight gain, it's going to affect your glycemia, it's going to lead to osteopenia, especially in the clinic. It's an unavoidable evil, but we do it. This is, you know, rheumatologists are very akin to treating osteoporosis because we cause the osteoporosis. So, yeah, I think, you know, it's constantly evolving. In terms, just to kind of bring it back to the concept of the lecture, most of these medications don't necessarily lead to additional musculoskeletal complaints. It's more of like the impact on our immune system. They become more susceptible to, you know, cancer, infection. That becomes the bigger issue. And so, you know, if you have a patient that is an athlete who's on these immune deficiencies, especially in the time of COVID, and they are going on a trip, or they're in a tournament and they're interacting with others, that's the thing that becomes challenging. How do you counsel that patient? You know, they probably need to mask up and they take extra precautions. And but you know, the great thing is these medications are now so targeted to just a specific part of the immune system. You know, it's not just, you know, you still have innate immunity. Maybe the drug is just affecting T-cell immunity. Maybe it's just, you know, affecting just the TNF level. So, you know, I think at this time it's still more of a tailored approach. But as medications advance, they've been able really to tone down unlimited amount of side effects. So it's great.
All right, and there was just a quick comment coming from Edward. Glucocorticoids are now prohibited in competition, and the status was according to the WADA prohibited list. So just needing a TUE for you.
Oh, I appreciate that. Thank you. Yeah, I mean, it did seem like something that you probably wouldn't. I didn't see it on the ban list, but I think, you know, certainly if there's ever a medication, you know, because the field is always constantly evolving, I think it's important just to make sure that you involve the specialist, and if there needs to be a specialized exemption doing it. But thank you for educating me on that. I appreciate that.
All right, awesome. So it was right around 120 people here. So I appreciate your time. Thank you, Dr. Brucker, for a great topic, and certainly one, you know, again, a little bit on the fringes, which is where we definitely like to live in terms of the presentations that we provide here. But definitely applicable. So, you know, definitely appreciate you speaking on the overlap, the intertwine there between sports medicine and rheumatology. And thank you to everyone for attending.
Thank you. It was my pleasure to speak, and you are all welcome. You can get it from Dr. Henny, my contact information, and I always love to hear other cases. It's great to be challenged, and it keeps you honest and helps all of us evolve with our own medical practice. But I'm more than happy to ever curbside or just questions, feel free to reach out. But thank you so much for the opportunity. I really enjoyed it.
All right. Have a good night, everyone.
All right. Take care.